Good morning, everyone, and welcome. So today we are talking about a really important topic for everyone, actually. Everyone, no matter how old you are or where you are, it's advanced care planning. I'm delighted to be joined here this morning by Sam. We're tucked here away at Eastern Health, which is very exciting. And Sam, tell me a little bit about how long you've been doing in the advanced care planning space in your role.
Well, I'm going to make myself sound like an old dinosaur now, but I actually, 2012, I started in this role, and myself and my colleague, we're a nurse-led service, and we worked out a combined nursing career of 70 years.
So, and add me now, and yeah, we've got 100.
So hopefully we can, I can share some knowledge, but I also think of the wisdom of life and everyone's experiences. So be really great to have any questions that you have, and I think Jodie's going to coordinate how we do that, but certainly feel very privileged to be able to speak today.
Great. All right, and this is Sam. We've just talked, Sam has over 30 years. We've just talked about that. And a key aspect of her role is providing education and awareness about what advanced care planning is. And she notes that she's in a privileged position to assist patients, families and carers to talk about advanced care planning. And it really comes back to quality of life as well too, if you start to think about that. And I'll hand over now and actually just put Sam in the front of the camera there. And yeah, if anyone's got any questions, and I'll sit back and listen. I'm really excited about that.
So this is really important, and I want to welcome an acknowledgement of country. And I begin today by acknowledging the traditional owners of the land on which we meet today, and pay my respects to the elders past, present and emerging. And I extend that respect to Aboriginal and Torres Strait Islander peoples here today. So today I'm going to talk about advanced care planning, the what, why and how. We actually have a little poll here. I just wondering how many people have heard of advanced care planning. So yes, no, not sure would be great. And one of the things you'll notice from my picture, I used to be different hair color, now I'm grey. Oh wow, that's fantastic. So the majority of you have heard of advanced care planning, and a few know and a few not sure. I would say that's unusual. Normally we would have the majority know and the yes and the not sure about the same. So that's huge. And one of the challenges with advanced care planning is the name doesn't tell you what it is. So a lot of times people think it's to do with finances. People, when I speak to them, think I'm going to come around and do their gutters or clean their house. But no, it's about your wishes for care. So one of the things I think is really important is there are some myths about advanced care planning. And the first one, it's just for old people. I just want to let you know the youngest person that I've assisted has been 19, but the oldest has been 97. It's morbid. Some people think it's all about death and dying and about not receiving treatment. In fact, it's not. So I'm going to talk about that. People think it all needs to be very legalized and is expensive. With going to a solicitor, you don't have to do that. So I can talk to you about options with that. And it's too hard. That I sometimes think I would sometimes say, I actually think can be really hard. It can be emotional, it can be challenging, but I'm going to give you some strategies about that as well. So one of the things with advanced care planning, and first and foremost, the lovely picture of the lady is 100 who's having a cigarette. We are a no smoking organisation, but the reason I have that gorgeous photos there is one of the things with advanced care planning is about thinking ahead for a time when we may be unable to advocate for ourselves, so for what is important for us, for what treatment we may or may want, and then who would we want to speak on our behalf. And the thing is, we also, as far as I'm concerned, the lady having a cigarette, she should carry on smoking and ideally have a drink as well. But sometimes people who are making decisions for us might make a choice that we wouldn't want. And also, we also have the right to make our own decisions and our own choices, which sometimes people might think are a bad choice, but it's what's right for us. And I think with advanced care planning, there's not necessarily any right or wrong. It's just the person's individual perspectives. And in life, opposites can attract. So sometimes the people in our lives have different views. So again, I'll talk through that as well. So one of the biggest things, and I think we kind of, being a nurse, and I don't know how many of you are nurses or in the health field as well, but one of the things I've realized is that sometimes we actually don't know that much about our own health. And one of the biggest things about advanced care planning is really knowing what's happening for me in my health, learning more about your condition or a condition or illness of a family or friend. And one of the things in that, you may have questions that come up at times, and it's okay to ask. And it's certainly important to talk through those views, those concerns. What does that mean? What would it mean if I accepted this treatment? Or what means if I don't do anything? What's the pros and cons? And I think what I would say is often people don't think they can ask those questions when they're seeing their specialists or seeing their doctors, but you can. I actually explain, I say to people, write your list. And one of the things I think is really important is sometimes knowing who you can speak to. Again, we'll talk more about that. But there is, on that point, there is a question here as well, another doodle poll. So as some of you have heard about this, one of the things I'm wondering, have you already started talking about your wishes and your thoughts? And if so, who are you speaking with? The reason I say that is because family is very broad. I'm a migrant, so I'm obviously an English POM. All my family is in the UK. I'm a single mum, daughter under 18. So here is a close friend for me. That's who I would, just so you know, where I am at. Because I would say my close friend is my family, if that makes sense. Well, oh, thank you so much, guys, because I think one of the things, what's really great, this is just to show you the, I think, the diversity of life and our thoughts. And the healthcare provider, no one said that, have they? No, that hasn't come up as anyone. And that is, I think, the reality of life as well, you know, that we may speak to people close to us, or we may not speak to anyone as well, because I think that's really, sometimes we keep our thoughts to ourselves and it's hard to articulate as well. Thank you. So one of the things I think I really want to emphasize here is we have the right to make our own decisions about our life. First and foremost, we have that. We're presumed to have decision-making capacity when we turn 18. There is different arguments around the world that say actually that is much younger than 18, but certainly in Australia currently it's 18. But you know, one of the things I think is with advanced care planning, it is about thinking ahead, thinking about what's important to us, you know, and it's one of those things that you only really think about it when potentially you need to, unless you're someone like me who often thinks about all these things. But again, it's really it's just a mechanism, I guess, a way of thinking and talking and sharing views. So one of the things, the biggest part of my role, and I think is for health professionals as well as for people, is that, I don't know if you know, and I'm talking about Victorian legislation here, but there is equivalent legislation in all states and territories in Australia. Now, in the law, there is the Medical Treatment Planning and Decisions Act in Victoria that sets out who the doctors will speak to if the person is unable to consent or refuse treatment for themselves. And the first one is a person appointed by the individual, and that is now called a medical treatment decision maker. It used to be called enduring power of attorney medical treatment. Those previously appointed before 2016 are still current and valid. Then you have, which is important to know, then you have the next one is a guardian appointed by VCAT to make medical decisions about medical treatment. Now, often VCAT guardians are actually often for financial matters rather than medical. So if you are a VCAT guardian for someone else, have a look at what authority you have, whether it's administrative or whether it does cover medical. And then we have family. So the first person on the list below is close and continuous relationship with a patient who is willing, able, and available. So the patient's spouse or domestic partner, that can be same sex. I have to say, one of those, I saw a couple, and I just that were been married for 60 years, and they had a great relationship, and they actually lived in different suburbs, which I thought that's a first. But they met together for coffee daily, and they had a wonderful marriage. So the patient's spouse or domestic partner, then a primary carer who's not a paid service provider. Then you let adult child, the patient, a parent, adult sibling. It's a very short list. Previously, there used to be nieces, nephews, aunts, uncles, cousins, but Victoria changed that to make it a really short list, because often what was happening was that a person that hadn't met that family member maybe, but was still a blood relative, was being contacted. And so that's not okay. And so now this is the list. What I would say is that sometimes when it comes to an adult child or the patient, it's the eldest child, but sometimes the youngest child might be the carer. So that's where, but sometimes carers don't want to make those decisions and will say, yes, I'm the carer, but I don't want to make that decision. So then it would go down the list. Yeah, so have you ever thought about who you'd want to consent or refuse medical treatment on your behalf if you're unable? You may have appointed someone. And just while you're answering that question, before the results come up, one of the biggest things I feel very strong on this is that sometimes people can fluctuate and they can improve and be able to make their own decisions with their decision-making capacity. And what we want to do is really support the person to make the decisions for themselves. So there is a support power of attorney as well that can help a person who may struggle with some decisions to make a decision. So the last thing we want to do is have a substitute, but equally, if there has to be a substitute, we want to make sure it's the person, is it someone that the person would want? Okay, so hopefully the answers are coming through. Oh, wow, everybody. That's fantastic. Because thank you, that's really good. I say that's really good because you've made that decision for yourself. One of the challenges when I speak to people is that the person they may want to appoint doesn't feel able to do that role, or they may feel that they don't feel able to talk about their views and thoughts. So one of the things I just wanted to flag here, and I've got this slide up as you can see, one of the worst things, and this will be for people that you may know that aren't attending today, but one of the worst things any one of us can do is give authority over our life to another, unless we trust them. I think you don't want to appoint the wrong person. There is mechanisms and safety nets in the system to where that appointment can be revoked, but obviously you have to be really, you ideally don't want to be in that situation. And it's really important that the person you choose feels able to advocate for you, knowing what you would want them to say. And I think having that conversation is really important. The other thing I think is also really, and this is from my clinical experience as a nurse, sometimes we appoint people, but we forget to tell others that we've done it. And it can be quite stressful. There's a family meeting and someone said, oh, Sam appointed me, and no one else knew. They can feel quite hurt. To give you an example, I was helping a gentleman who had kidney disease, and he said, oh, look, I'm planning to appoint my ex-wife as my medical decision maker. And I said, oh, yes, okay, why are you thinking your ex-wife and not your current wife? And he said, oh, she's really hard, and she really will do exactly what I want and takes no prisoners. And he said, but he said, but whereas my current wife gets really upset when I get unwell, and I'd like her to just be my wife, you know, she just so, but not have to be bothered with all the doctors and all that stuff. And I said, oh, I said, great. So have you told your current wife you're going to appoint the ex-wife? And then there was like stone silence. You could hear crickets. And I was like, oh, mate, you're going to be on your third marriage beforehand. I think you best have a conversation and make it so they're all okay to be in the same room together and they know where they're coming from. And you can also give your ex-wife an instruction to speak to your wife prior to making decisions if there's time. I said, so I would strongly recommend you do that. So you've all appointed a medical decision maker, or you've already selected who you'd want to appoint. You don't have to actually appoint. If they're under the legal hierarchy, they could be that role naturally. What I would say, having them appointed means that you haven't left it to the default, and you're really clear that that's the person, which can be really helpful. You can appoint more than one person. And I would say you can do this for free. And there are offices of the public advocate in Victoria, but there are also in other states and territories offices of the public advocate, and you can actually have them, your appointment witnessed by a doctor, police officer, pharmacist. There's a whole list of who can be authorised witness. But you have to have decision-making capacity to do this, and they have to accept that role. So this is life is unpredictable, so how can we plan ahead? I completely agree with that. I think there are lots of what ifs, and certainly the elephant in the room, and I don't know if you've experienced this with being in an appointment with a doctor or anyone else. I won't mention if you don't, fine by me, but it is hard sometimes to think ahead. So when I speak to people about this, and again, it can be people who have illness, people who have never had an illness, people who have had life experiences with others. So that last dot point, past experiences with family or friends, where healthcare decisions had to be made. And they have things that they feel quite certain about, you know, in their life views. So there's no, like I said, there's no right or wrong. And to give you an example, I don't know if you've heard with Dying with Dignity. One of the doctors in Barwin House in Geelong in Victoria, he is amazing, and he talks about how dignity means different things to different people. So for some people, dignity means going off and doing your bucket list, and no thank you, I don't need that treatment, I'm off. For other people, it's having every possible treatment possible and to give their body every chance of responding. So no treatment is too much of a burden. They give me everything that you can throw at my body, I'll take it. And I think there's no right or wrong, they're just different perspectives. And that's what he meant by dignity is different things to different people. But what is important to you? What do you likes, your dislikes, were your beliefs, you know, and are there things that you're worried about? What I would say is most of the time when I speak to people about things they're worried about, it's actually everybody else. But one of the huge things in their family and all the people they care and love, one of the huge things they are worried about is not being able to drive anymore. That can be hugely isolating, or so that's one of the things about that independence, to go when I want to be somewhere. So that can be something people are worried about. So this is a great tool that I use a lot, and because I think this is also about conversation starters from Advanced Care Planning Australia, and it's like, what's a good day look like about life? What's in your bucket list? This is something that I think people can, anytime, you know, talk about what's important to me and answers. And like I say, it's one of those things that how would you answer that question? Because if I get referrals to go and see a person, I often say to the family, well, how would you answer that? Or what would you say for yourself? Because it's actually important for them to know what your views are as well. So I think this is can be really helpful tool for conversation starters. Now, one of the other things that people sometimes do, and this is something that is completely, everything in advanced care planning is voluntary. But sometimes people struggle to talk to another, or they don't want to talk to another because they find that interaction difficult, but they actually find it easier to write down their thoughts. Now, there is something called an advanced care directive, which is a legal form, which has to be completed with a doctor, but you can use it as a tool to look at your thoughts and wishes and what's important to you. But sometimes people do an advanced care plan where they might write a little letter to say, this is, if anything happened to me, these are the things that I'd like you to know. And the term living will kind of makes sense to me with that terminology. But it's something that can help because we never say the same thing to our family members at the same time. So one of the things of having things written down, it means everyone's on the same page. They can see what was written when, you know. One of the things with these sorts of documents, they only come into effect if there's a time when you're unable to make your own decisions about your health care. And I think that's really important to know, but they can inform your current treatment. So for example, if any of you are Jehovah's Witnesses, I would suggest you've probably already done a directive regarding your blood products, what you would accept or not accept, and that would inform your current care as well as future care. And again, these documents, you keep originals, and we recommend copies are given to definitely your medical treatment decision maker, your family GP or local hospital, but they're in your control of who has what. I wanted to show you this, and I didn't ask which state and territory everyone's from, but there is a form that's been developed by the Victorian Government and Department of Health called an Advanced Care Directive for Adults. So this provides a template. One of the things it's got here, my current major health problems are, I was helping a lady who was in her 90s do this, and she wanted to do this because she had lots of children, grandchildren, and she just wanted to make sure they all knew what she wanted. And regarding my current major health problem, she put, I'm 95, everything. so it's your own way of doing it. But what I would say, and this is me putting my hat on as a nurse, it's something that paramedics can see, GPs, they're starting to recognise that this is the type of form in Victoria, but you don't have to use this. But the directive can only be completed by the person for themselves. There is another form called an Advanced Care Directive for Adults for people signing on their behalf. Now, that is still for a person who's able to make their own decisions but physically cannot sign for whatever reason, but they still have to have decision-making capacity to do that. And one of the things when we talk about with people being able to make or communicate their own decisions, I work with people with dysphagia, people who we use all sorts of tools. You know, just because someone can't verbalize doesn't mean they can't communicate. So but also if they're unable to use their arms or can't hold a pen, it's often not uncommon in hospitals with swelling hands and different things. So there is a way that we can support the person to document their wishes if they want to do it in this way. So this is one of the things, and I've left time for questions, but one of the things when I talk about this is whatever feels right for you. Okay, this is when should you start. It's entirely up to you. You know, I'm a bit of a future planner, but I still haven't got all my ducks in a row, so I'll just put that out there. But I think it's good to start talking about your health at any stage in life. And, you know, it is really, really important that we do share our thoughts and feelings. And like I said, there was one lady who husband didn't like to hear her talking about her thoughts and feelings, so she would get in when he was in the bath. and then go and start talking to him then because he couldn't escape. So certain things and certain strategies are how people communicate is really good, I think. Everyone's different. So this is really important, and I think there's lots of people where you can actually access to find support. You've got your GP specialist and MS Plus Connect, fantastic. There is, again, Australia-wide, ACP Australia, they're a federally funded organisation, and then you've got the sites and Public Advocate Guardian sites. So there's a lot of it out here, and there's a lot that can be done for free, which is really important as well. Questions? So thank you very much for listening. I hope I haven't. Hope I've made sense.
I'm going to make a quick start, Annie. Before I'm going to jump in before you. I think, Sam, one of the misconceptions that I find, you know, being a nurse in the past was that that when these decisions need to be made, it's a time of clear communication and control. And often in my experience in hospitals, it was the most out of control of any situation, and that's where these things were really helpful. You know, they were so important in terms of having those. If the family all were on board with what they knew what happened, it was so much. Have you found that to be true?
Oh, absolutely. There's nothing, excuse me, frog in my throat. There's nothing, medical crisis is one of the worst times, and having a phone call and asked over the phone is even worse than face-to-face. And we know through COVID how traumatic that was for lots of people. But certainly what the research tells us is if people are unsure, they 50% of the time they walk away going, I don't know if I made the right decision. I don't know if I did the right thing. So it's incredibly hard if you're asked to make a decision and about should we or shouldn't we, what would mum or dad want, or your sister want, what would your husband or wife want. And I think what I would say is having those conversations early about your thoughts and views. It really, even if it hasn't been about a specific treatment, they can say, well, they always generally talked about, you know, life is precious. They were really hoping for this, this, and this to occur. So I think they would be willing. I think they would be willing. And I think if you can sort of base your decision on that kind of conversation that you might be having, can be really good. Equally, you might say, oh, I never want this absolute line in the sand. That is my line in the sand. If that ever occurs, just let me go. I don't want that. And that again is really helpful for you people to know, you know, because it's very hard to make a decision for someone else when you love them and you're trying to separate your brain to your heart. So having something to refer back to is invaluable.
And it's always chaos communication, and it's one doctor saying one thing and then the nurse saying another thing. And then I think I often thought that the kindest thing that you can do for your family is have this ready for them, you know, so that they're not, and a family arguments, you know, after money comes health, or vice versa. So, you know, they're the two things that just create such family conflict, because in the moment, it's when you really, when you really feel different things. If feelings are so strong, and so unless people are very clear, there'll be one sister who desperately wants to do everything, and the other sister who says this. So unless people know what you want, there can be such family conflict. So that's one of the things. Annie, was there any other questions around that?
Yes, a couple of questions have come through. Laura is asking, can your medical treatment decision maker override your advanced care directive?
Oh, Laura, that is a brilliant question. So I'm glad you raised that. So actually in the legislation, what it says is that your medical treatment decision maker should follow your values, preferences, and treatment decisions. And there's actually, they can actually, it says that they can give them, it doesn't say penalty points. I'm not quite sure what that means, actually, a penalty point for a family member or medical treatment decision maker. But in practice, now this is one thing I'm going to say in practice, there are, with the directive, there's the instructional directive about your consent or refusal. So for example, the Jehovah's Witness one, that can't be overridden by anyone, that component of it, and that bypasses your medical treatment decision maker. So the only way that can be overridden is via VCAT or court of law. And so that's that. But with your values about treatment and views, if your medical treatment decision maker said, look, I know this is written down, but last week, this is what Sam said to me. She was going to change this because she no longer believes X, Y, and Z. As a, we would have to sort of take that on good faith, but we'd also have to say, look, we really have a duty of care to Sam. I'm using me as an example, sorry, Sam, to actually follow her wishes. So is it okay if we speak to other people? Because I think we need to make, this is too important. So one of the things I would say as well, though, in my previous role, I used to be an intensive care nurse and organ donor coordinator, and particularly with organ and tissue donation, there's no right or wrong. But different perspectives can occur. So I think one of the things is saying, you know, I know that's your view, but what would Sam say? And they'll go, oh yeah, I know I disagree with it, but I know that she would want it, so okay. So I think it comes down to that thing. We try and support the person, but from if they haven't got a directive, if they haven't got an advanced care plan, that's when potentially it's all verbal. It can get a bit messy, and then, but we still want to make sure that there is, how can I say, consensus within the family. You know, if there's more than one person there, people can appoint more than one medical treatment decision maker. I have been in times with families where the medical treatment decision makers have different perspectives. And I don't mind that. I actually think they're coming from it from different views. And it's really important to talk it out, because why they're saying one thing is because they've had that different conversation, but then it's always bringing it back. But it can, if we don't talk openly about these things, it can certainly leave lots of issues for families ongoing. And that's not really what the person would have wanted. Yeah. I hope that answers your question.
Thank you, Sam. Another question has come through from Robert. Robert's saying thanks for the topic seminar, which is great. And his question is, what is the overlap between an ACP and an enduring power of attorney? which takes precedence?
Right, so that's really good. So the enduring, is that enduring power of attorney financial?
Medical.
Medical. So your ACP takes precedence. They should, it's like a, I don't know what you do, Robert, for work, but it's like a work instruction. So they should follow your instructions on that. That's how it should be work in practice. Yeah. But sometimes what we write down may not actually fit what nicely into that what's occurring at the time. So then they'll work with the doctors and the nurses at the time, say, okay, this is what I think, this is what this means, this is what I think this meant. So being clear in what your views are is really important, because that can be a problem. But technically, the ACP is the one, or the ACD is the one that guides and instructs your medical decision maker. Also, so for people who don't have an appointed medical decision maker, and I know you all said yes, you've got a person that would speak on your behalf. But if you didn't have somebody, then your directive would be your voice, or your advanced care plan would be your voice. That's how we would take that in health. And then we would just clarify. If you don't have anyone, then it's the Office of the Public Advocate, or that can make a decision on your behalf if required. Or fail-safe in that system. Yeah.
Thanks, Sam. Margaret mentions that the form that you put up on one of the slides was a useful starting point. But when you're considering this, is there more of a medical orientated list or of something, at least types of medical decisions that may need to be made to assist in having the conversation with the appointee?
Yeah, look, I think that's a really good point. There are certain things I think are really helpful, and this comes back to knowing your own health. But in Victoria, there's a instructions to go with doing a directive, and I think even if you don't do the directive, the instructions are really good. It's a scale of how I feel about certain situations. Life would be unacceptable, and it has a, I can share that with and forward that on to you, because I think that talks about if I couldn't eat or drink for myself, if I couldn't do this. One of the things that comes up a lot for people is resuscitation, surgery, whether or not they'd want to have, sometimes even different, depending on what's going on. If a person has lung disease, whether they be wanting to have a ventilator for to help them, or they'd be okay with a mask on their face, you know, for non-invasive ventilation. And sorry if I'm getting more technical, but you probably might be more familiar with intubation and CPR from the TV and different things like that, or you may be trainers yourselves. But certainly people often have, what I would say is what you do is you don't want to be undertreated. Sometimes people look at what's the outcome, is it reversible? If it's reversible, then yeah, I'd be willing to give myself a go. Or they might say, look, I'm at this time in my life, I've had that treatment a number of times, I don't want to go back there because the recovery is too hard. And so this is where it kind of comes on as an ongoing communication, I would say, rather than necessarily a definite checklist, because it depends how you are at that time in your life.
Thanks, Sam. Question from Joan. I live alone in Australia. What are my options and who can I appoint?
Yeah, great question, Joan. So now in this day and age of IT savvy, you can actually appoint someone who's overseas as your medical decision maker. You can do that completely. They just have to be contactable. And so what I do with people that have, like myself, migrant, so what you can do is you would, in Victoria, the form is you can go to your and appoint, say, I want to appoint me. I wouldn't, well, no, I would, I would do whatever you want, Joan. But, and then you appoint me, and then what the sign-in of acceptance form, then I say to Joan, I'd tell you, email that to your friend or your family member. They would sign it, get it witnessed there. They email it back to you. When all the documents are together, that's your contact person. So it's not uncommon this time. We have people that have medical decision makers in the US, family members travel, as long as they're contactable. That's the key thing. Sometimes people can live next door, but they never answer their phone and they're never going to be there for you at that time. So it's really about, if that's the person you trust, we'll track them down. And if they want to give them their contact details and ways to do it, it works well.
Okay, another question from Robert. Is the ACP stored? Is it an electronic copy? Is it on mygov.com? And can it be adjusted easily online if you need to change it?
Oh, look, I think to myself, that would be my, the answer is, I suppose, essentially it's not online. You can upload it into My Health Record. There's a paper version. But what I would say, in the doctor in Geelong has got something called My Values. And I've done it, and it's like a, I've got my phone here, and you can, oh, sorry, it's my dog. Look at my dog on my daughter's back, sorry. But basically on that, Robert, you can download it, you can answer questions, and it gives you sort of scale how you feel about life, and then your wishes, and then you can auto sign it and flick copies off to families and friends. So a lot of people are like that, who prefer the electronic one, and then you can update it as you want to. So I would say for that platform, I'd go for My Values, and that's, you can access that anywhere. I think that can be useful. What I do think as well is, if you do a document, a new document automatically supersedes the old one. But it's just making sure that people know that you've done a new document, I guess, if you do it that way. But the My Values app, you might like to have a look at that one.
All right, excellent. Thank you, Sam. No further questions have come through at this stage.
I just had one other question that we got before the webinar as well too, was where does voluntary assisted dying fit into this? You know, where does it all fit?
Yeah, no, that's really important. And I think one of the things with voluntary assisted dying is that you have to have decision-making capacity to make that decision for yourself. And there's a load of regulations in the legislation, and particularly one of the things is that because you have to have decision-making capacity, and because you have to have a life-limiting illness where death is likely to be in 6 months or 12 months, depending on what type of mechanism of disease it is, a directive, it doesn't work. So a directive, you can't consent to voluntary assisted dying in a directive, because a directive is enacted when you don't have decision-making authority. What you can do in a directive, what you can do, and what people sometimes do, is they say, look, I'm a member of a euthanasia society. I believe if ever I was in these situations, I would do this. That is a value statement. So I would actually say, yeah, put it in your advanced care directive in your value sections, but you can't put it as an instruction, because it cannot be followed legally, because at the time when that's enacted, the person doesn't have decision-making capacity. Another example of that is, say, for body donation. Lots of times people talk to me about they want to donate their body to science. A person can only do that for themselves, and no one else can donate their body to science except the person for themselves. So again, that has to be done before they lose decision-making capacity. I hope that's clear. There's a lot of information on voluntary assisted dying. But it can be quite overwhelming. But I certainly think if that's people's views, it's good to talk about that. Yeah. Okay, I've got a few minutes left. I don't know if there's anything. I want to say thank you so much for listening, and certainly, you know, I look forward to your feedback. If any other questions come through, then we're happy to answer. I think Annie or Jodie will probably forward to her, and I can forward that scale. I think it's really, really good about, you know, how you might feel about things, and in there it's got, I can't answer this now. This is how I feel about that. It's something that I think is really helpful, because often it's not rather than specific treatments. It might be, hey, what's the outcome likely to be for me? That is, how am I going to live with this? You know, and sometimes people say, I can't plan ahead because I don't know how I'm going to feel about things. That's okay as well. You know, that's okay as well.
Yeah. I found that in clinic when I was in the MS clinic. I talked to lots of people, and lots of people had different reactions to that conversation, but it was a hard one to initiate amongst family. It's not an easy thing, and that guide is really good to say, hey, I want to talk about this, or I've watched this webinar today, I want to chat about this, and I've had a think about this, and people really change their minds. You know, what you think you're not willing to put up with, actually you do.
Yeah.
And so it's really important that it becomes a living conversation, not just one in a piece of paper, because it really was so true that I found in progressive diseases, that people who thought I would never want to live like that actually really said, actually, what I value most is being able to share love with my family, and then I can do that in a whole lot of different ways, no matter what my physical capacity is. And my eyes, having this conversation, my eyes were open to that a lot, to say this needs to be something that people talk about all the time, and not something you just do once, because you actually change what you value and what you accept. And workarounds, you know, people with MS, living with MS, are the best people at workarounds that I've ever seen. And so it's really important, I think, that they become living documents. So just the next slide, Annie. So this is a bit about MS Plus. So we've got a few services at MS Plus. Many of you are probably familiar with this. Just if you've got any questions, please don't hesitate. This will be available on the resources hubs afterwards, and just for people, if you want to direct them to as well to have a listen, or to get some of those tools, we'll certainly have them available as well too. What we often do is summarise our webinars, and just for the key tools for people to access easily as well too. We also have podcasts and other articles. And then if you want someone to chat to, next one, that's our Plus Connect line. So if you want to email us or give us a call, then please do. There are people our team who at Plus Connect are certainly available to have a chat about this. A lot of them are social workers, so if they can't answer the questions, they might direct it to our nurses. We've got Sam's details, so we can get in touch with her to be able to say, hey, this is a curly one, because some of the questions that you guys asked, I wouldn't have been able to answer. So I'm glad we have Sam's details for later. And I think that's it, isn't it, Annie? Is there any more slides? No, just thank you all for listening and being part of this. And we will Annie will take over now. And if there's any other questions that you think of afterwards, don't hesitate to get in touch.
Thank you. Bye, everybody.
Bye.